This is Drew Wilkinson, Chief Resident in Neurological Surgery at the University of Michigan, along with my senior author, Dr. Cormac Marr, Professor of Neurosurgery at the University of Michigan. We will be discussing pediatric arteriovenous malformations with a particular focus on differences between pediatric and adult arteriovenous malformations. True peel or parenchymal arteriovenous malformations, or AVMs, are congenital lesions resulting from the failure of arteries and veins to differentiate from vascular channels, although cases of de novo development have been occasionally described. The classical appearance is of a nidus of vessels of mixed venous and arterial character fed by arterial inflow and emptying into one or more draining veins. Different stereotypical phenotypes of AVMs have been described. Some have a nidus that can be characterized as compact, others are characterized as diffuse. Pediatric AVMs in particular have been noted to have a higher occurrence of linear vein-based malformations. AVMs can arise both as part of a syndrome or spontaneously in isolation. Hereditary hemorrhagic telangiectasia is the most common syndrome associated with AVMs. Spontaneous occurrences of AVMs are much more common than syndromic occurrences, both in children and in adults. Some series suggest that children more often present with AVMs of the basal ganglia, thalamus, or posterior fossa. Most series agree that children more often present with hemorrhage as compared to adults. Other presenting symptoms can include seizure, headaches, or other neurological deficits. An increasing number of AVMs are being found incidentally, which probably reflects an increased use of imaging over time. AVMs are most often first noted on non-invasive imaging, usually with a CT or MRI. Children with unexplained hemorrhage outside of the perinatal period in a negative CTA likely warrant diagnostic angiography to rule out an underlying arteriovenous malformation. Those in whom an angiogram is first negative with a high suspicion of an underlying AVM likely warrant repeat angiography to rule out a small compressed AVM. The greatest predictor of AVM rupture is prior rupture, with a relative risk approximately 5 times that of previously unruptured AVMs. Particular to children, an increasing awareness of the adverse effects of radiation has led to efforts to reduce radiation exposure during angiographic procedures. Tight collimation of radiation fields, pulsed fluoroscopy, dose reporting, age and sex-specific shielding, minimizing of the detector-patient gap are all technical modifications which have been used to reduce the dose of children undergoing angiography. After initial discovery and treatment, repeat catheter angiography is usually performed only to confirm lesion obliteration, with MRI used for more routine surveillance. Once an AVM has been discovered, the first consideration is whether to treat or observe the AVM. No large studies of observation versus treatment in children have been performed. The 2 existing large observational studies did not include children. Current consensus opinion, however, usually advocates treatment for most pediatric AVMs, except when it would cause unacceptable morbidity, especially in patients who present with hemorrhage. The longer expected lifespan, susceptibility of the brain to radiation injury in children, plasticity, and smaller blood volume in children all alter the considerations of whether and how to treat an AVM in the pediatric population in comparison with adults. Contemporary AVM treatment generally entails resection with microsurgery, radiosurgery, pre-surgical or pre-radiosurgical embolization, or a multimodality combination. Some studies suggest that the complication rate with either surgery or radiosurgery may be lower for children with better post-treatment MRS scores. Specific to children, linear vein-based AVMs, which are more common in children, may be particularly well suited for surgery. Neuroplasticity of the pediatric brain may also facilitate recovery after treatment. No large study has compared treatment modalities in children. Although endovascular treatment is used as the standard of care for definitive treatment of vein of Galen malformations, it is used primarily and almost exclusively as an adjunct therapy for pediatric AVM treatment. In cases where definitive microsurgical resection has been elected, preoperative embolization may help facilitate surgery with less blood loss, which is a particular concern given the low circulating blood volume in pediatric patients, especially the very young. Embolization is also undertaken sometimes before stereotactic radiosurgery to reduce the AVM volume to allow for radiosurgery within acceptable dosage limits while increasing obliteration rates. Specific concerns regarding embolization in children are the safety and toxicity of embolization materials in the pediatric brain, radiation exposure, and the potential difficulty in cannulating smaller pediatric vessels in comparison to those of adults. Ethylene vinyl alcohol copolymer, also known as onyx, as well as NBCA, appear to be safe in children. Dimethyl sulfoxide, or DMSO, a solvent necessary for onyx use, has been associated with pulmonary edema, but has also been used without evidence of permanent morbidity. One large series reports that complication rates of embolization in children are lower than those in adults. Surgery remains the favored treatment if it can be accomplished safely. As in adults, the Spetzler-Martin grading system is used to predict the risk of surgical morbidity on the basis of AVM size, pattern of venous drainage, and eloquence of adjacent brain tissue. Other considerations in children include the size of the child and their ability to tolerate surgery, the eloquence of the area and its effect on daily living during their long expected lifespan, as well as the surgical corridor that would be necessary for treatment. Linear, vein-based AVMs, more common in children, may be particularly well-suited candidates for surgery, as the surgical corridor may already be well established by the vein. Specific technical considerations for AVM surgery are reviewed elsewhere, but in general, resection proceeds by dissection down to the AVM in the perilesional area of gliosis, obliteration of the arterial supply, and lastly, obliteration of draining veins until the AVM is then removed. As mentioned previously, the smaller circulating blood volume is a particular consideration with children, and preoperative embolization may help avoid blood loss. Complete AVM resection provides immediate protection from the risk of AVM rupture. Stereotactic radiosurgery, or SRS, has been used increasingly to treat AVMs whose location, size, risk profile, or other factors preclude safe surgical resection. The adoption of focused irradiation or radiosurgery as therapy for pediatric AVMs has lagged behind its initial use in the adult population, largely because of concerns regarding the effects of radiation on the developing central nervous system, the longer expected remaining lifespan of patients, and questions about its long-term durability, and the consequently increased potential for radiation-induced malignancies in the future. Most current studies, however, show good but not perfect obliteration rates with relatively low rates of radiation-induced cysts or meningiomas. Most centers report dosing in the range of 18 to 23 gray, most commonly 20 to 22 gray. Volume or dose-staged stereotactic radiosurgery has also been increasingly adopted for large AVMs difficult to treat by surgical methods. One disadvantage of SRS treatment for AVMs is that it doesn't, particularly those which have ruptured, is that it provides no immediate protection. Obliteration lags 2 to 3 years and sometimes longer from SRS treatment. Increasing numbers of patients are being treated with 2 or even 3 treatment modalities for large or high-grade lesions. Pre-radiosurgical embolization may reduce the volume of an AVM to within a size constriction more amenable to radiosurgery within acceptable dosage limits. Pre-surgical embolization may facilitate surgery as previously described. Pre-surgical stereotactic radiosurgery may reduce the size to facilitate surgery and give a gliotic rim more amenable to resection. For large lesions in eloquent areas of the brain not amenable to open surgery, the primary treatments are no treatment, staged radiosurgery, or multimodality therapy, primarily with pre-radiosurgical embolization. Post-treatment surveillance or surveillance when observation has been selected are particularly important in children. In distinction with adults, AVM recurrence has been noted after angiographically documented resection in children. This may reflect the frustrated former feeding vessels to the AVM in the setting of pro-angiogenic factors in the developing brain. Repeat surveillance with angiography with at least one angiography in adulthood is recommended, though again considering radiation concerns in kids. In summary, AVMs are the most common cause of brain hemorrhage in children after infancy. Their potential long lifespans push towards treatment in children as compared to adults. Pediatric AVMs are often vein-based and may recur after resection. Microsurgery and stereotactic radiosurgery are the primary treatment methods with or without pre-treatment embolization. Neuroplasticity of the pediatric brain may lead to improved outcomes with treatment.